Good afternoon. We're going to go ahead and get started with today's presentation. So last week, Dr. Naga talked to us about echo assessment of the right ventricle. We're going to continue on with that theme, and today I'm going to talk about CMR assessment of the right ventricle, and Dr. Waleed Ahmed will talk about cardiac CT assessment of the right ventricle. So here's the background. And again, this is one of the areas where I think, in the past, we really didn't pay a lot of attention to the right ventricle. But I think as you'll see, it's gaining more and more importance these days. So I'm going to start off with a little bit about the background of the right ventricle, talk a little bit about the basic pathophysiology of right ventricular dysfunction, and then really focus on how we do assessment of the right ventricle by CMR. And then later we'll have talks on how we assess tricuspid regurgitation in patients by MRI. So a few basic things I think to keep in mind. So obviously the amount of blood that the right ventricle will pump out will be the same as the left ventricle, right? In the absence of a shunt, the stroke volume should be the same between the left and right ventricle. But the right ventricle is a bit larger. It's about 10 to 15% larger in volume than the left ventricle. And so as a result, if they're both giving a similar stroke volume, the RV ejection fraction is going to be a little bit lower than the LV ejection fraction. Also important to recognize that the right ventricle is pumping against a low pressure system, the pulmonary vascular system. Pulmonary vascular resistance we know is much lower than systemic vascular resistance. So the stroke work that the right ventricle generally has to do is only about 25% of the stroke work of the left ventricle. And as a result, the RV is a thinner wall, much more compliant structure. And so in general, whereas a normal LV wall thickness is about 10 to 12 millimeters, a normal RV wall thickness is on the order of about 3 to 5 millimeters. Now, important to also kind of recognize that the shape of the right ventricle is a little bit different than the shape of the left ventricle. It's got a unique shape, and oftentimes it's hard to directly image the right ventricle in any given view. A couple of things I think are important for us to recognize. So here's an example of a 3-chamber view of the right ventricle. So the 3 chambers that we're seeing here is the right atrium, the right ventricle, and then the outflow tract and the pulmonary artery. And this region right here is oftentimes referred to as kind of the inlet or sinus region. And this region underneath the pulmonic valve is referred to as the infundibulum or the conus. All right, so important to recognize that the right and left ventricles are interlinked. One is they share a wall together, the interventricular septum you can see. We commonly kind of think about that as the left ventricle, but it actually should be also thought about as a wall that has an influence on the right ventricle as well. There's mutually encircling epicardial fibers. So there's fibers that run around the myocardium that affect both the left and right ventricles. Did I skip past something here? Okay. And then important to recognize that the attachment of the right ventricular free wall is to the anterior and posterior septum. So oftentimes you can see here the anterior wall of the right ventricle attaches to the interventricular septum. And really that separates the anterior wall from the anteroseptal wall. And then down here inferiorly, there's also the inferior insertion of the right ventricle, and that separates the left ventricular septum, the inferior septum, from the inferior wall of the right ventricle. And then also importantly, the LV and the RV both share the pericardial space. And so obviously you can see significant dynamic effects when there's pericardial pathology as well. Also important to recognize that if we look to say the RV function, what segments contribute to that, the interventricular septum and the RV free wall are thought to contribute almost equally to RV function. Now, one of the unique things about the right ventricle, though, however, is that there's much more significant longitudinal shortening And what I mean by that is that's the base to apex descent. As you can see in this example here, if I've drawn a line here, which is the red line, at the mitral and tricuspid annular planes, if we look during systole at the amount of descent of the mitral annular plane, compare that to the amount of descent of the tricuspid annular plane, you can see that there's much more annular motion for the right ventricle, and as a result, there's more longitudinal shortening. And so longitudinal shortening is a greater contributor to right ventricular stroke volume than short axis or circumferential shortening. Also important to keep in mind, if you look at the shape of the right ventricle, it's almost a funnel shape. And so as a result, oftentimes when you're looking at just a short axis view, it may not seem like there's that much of a difference in size of an area between systole and diastole on any given short axis view. But it's important to recognize that any given imaging plane that you have is actually measuring a specific space or location in space. And as the right ventricle is contracting down, the larger or wider part of the funnel actually comes down. So as a result, in diastole, you might be imaging this area. In systole, you're imaging an area higher up in the right ventricle. So as a result, it may look like there's not that much of an area reduction, but that's why it's always important to look at the long axis views of the right ventricle as well, to incorporate both the circumferential as well as the longitudinal motion. Now, what about the coronary circulation? So if you look at the interventricular septum, the anterior portion of the septum is supplied by the LAD, the inferior portion is supplied by the RCA, and then the free wall of the right ventricle is supplied by acute marginal branches that arise from the RCA. Okay, what's the response of the LV and RV to experimental increases in loading condition? And this really shows you that if you look at the stroke volume as a percentage of what the normal stroke volume would be, if you increase afterload for the left ventricle, you get a small reduction in stroke volume. Look at the same relationship for the right ventricle. It's a much more sharper drop-off. So the right ventricle is much more sensitive to any increases in afterload, so that small increases in afterload can result in a significant reduction in the right ventricular stroke volume. So recognize that the RV and the LV are distinct entities. They're both ventricles, but they behave very, very differently from each other. Okay, so let's talk a little bit about the pathophysiology of the right ventricle, and then we'll get into how we do assessment by MRI. So if we look at right heart failure, there's really a variety of different conditions that can cause that. Commonly, it can be either pressure overload or volume overload. Pressure overload, the most common scenario is really something that's causing left-sided abnormalities that then leads to increased pulmonary artery pressures and then therefore a pressure overload situation on the right ventricle. But obviously volume overload can occur either from intercardiac shunts or from valvular regurgent lesions. You can have RV ischemia and infarction, although again, it's much less common than the left ventricle. There can be an intrinsic cardiomyopathic process, so just dysfunction of the myocardium. Oftentimes, RV dysfunction is associated with LV dysfunction, so that there's some cardiomyopathic process that could affect both ventricles, but there are conditions that could affect just the right ventricle. And then complex congenital heart disease can also be a cause, and then pericardial disease can also be a cause of right ventricular dysfunction and right heart failure. And if we kind of break this down into more detail, if we look at the pressure overload phenotypes of right heart failure, most common obviously is from left heart failure, but also things that increase pulmonary arterial pressure, such as a pulmonary embolism, other causes of pulmonary capillary hypertension, if there's a right ventricular outflow tract obstruction, if there's peripheral pulmonic stenosis, or some of these other congenital abnormalities that can be associated with right ventricular pressure overload phenotype. RV volume overload phenotypes would be tricuspid or pulmonic regurgitation, or intercardiac shunts such as an atrial septal defect, anomalous pulmonary venous return, and then some of the more uncommon conditions listed here. In general, the RV tends to adapt better to volume overload than to pressure overload. And again, if you remember that slide I showed you, the RV is much more sensitive to increases in pressure, to pressure overload than it is to than it is to volume overload. And then this is really kind of the relationship between RV ejection fraction and wall stress. And you can see that RV wall stress is low in normally functioning ventricles, but that RV wall stress is high in the setting of significant right ventricular dysfunction. And then we also know about the ventricular interdependence, that the LV and RV can affect each other. So especially classically, you think about this in the setting of a pericardial constraint, where there's a fixed volume within the pericardial space. So as a result, if the RV is dilating, it's going to come at the expense of the LV. And even outside of overt pericardial pathology, even in relatively normal pericardium, oftentimes there is an interdependence. And so you can see people who have a very large right ventricle may oftentimes have a smaller left ventricle. And it can be one from the pericardium, but also from the fact that as you have RV dysfunction, it then leads to less LV filling. And as a result, the LV then will be underfilled and will appear smaller. So one of the things, obviously, is when you're trying to determine what's the size of your chambers, it's easy to kind of say, well, let me just look at the LV, let me look at the RV, and one chamber looks bigger than the other. But it's important to recognize that you should really look at it from the standpoint of what is the actual volume or dimensions, not just looking at relative relationships. And then, again, this is just talking about the hemodynamics in progressive pulmonary vascular disease, where as you have increase in pulmonary vascular resistance, you'll gradually begin to see a reduction in cardiac output and an increase in pulmonary artery pressures. So again, just to kind of summarize the causes of right ventricular dysfunction, most common is due to left-sided abnormalities, but can also occur from pulmonary hypertension, from volume overload conditions, and also from intrinsic RV pathology as well. So let's talk now about how we assess the right ventricle by CMR. So Dr. Naga last week talked to you very nicely about how echocardiography can be useful. Recognize that in situations where you have suboptimal echo images, that clearly is going to be a case where CMR is going to be beneficial. The other area also to keep in mind is that oftentimes, even with good echocardiographic images, where you can see the left ventricle quite well, sometimes the right ventricle may not be as well seen. And those are also situations where MRI can be very useful. So in assessment of the right ventricle, going back again to the fact that the shape of the right ventricle is not just a nice spherical shape like the left ventricle, it's more of a crescent shape. And it's important that when we're assessing this, that we try to minimize geometric assumptions, because geometric assumptions can be very wrong, especially with the right ventricle, with the shape that it has. And so, in general, two-dimensional derived estimates of RV ejection fraction are not recommended. And really, this applies both to echo or to MRI because, again, of the unique shape of the right ventricle. And so as a result, you really want to think of the right ventricle from a three-dimensional standpoint. And so I'm going to show you also why it's important, where by looking at a single 2D view may not be completely representative of what the size of the right ventricle is. So if I show you three example scenarios here, where these are all look like four-chamber views. Example 3 here is a four-chamber view where it's cut a little bit more anteriorly, so you're going a little bit more to the anteroseptum, and as a result, you can see because of the shape of the right ventricle, if you cut it here, the size of the RV that you get is smaller. Versus if you look at on the left-hand side at example 1, where you've done a imaging plane that tries to go through the maximum RV dimension, then your two-dimensional view that you have is going to give you a larger right ventricle. And so I think you want to recognize that the size of the RV can be a little bit different just based on, even if it's a four-chamber view, just based on the angulation that you have. And that's why in echo you want to do specifically an RV focus view. On MRI, since the way that we obtain the views is actually by looking at the short axis view and prescribing the plane, one of the things we always stress for the technologist is for the 4-chamber view, you want to do it so that you maximally open up the right ventricle. And as a result, you see the largest RV. So one of the things also when you're looking at images, you want to recalibrate your eyes, because oftentimes on echo, you have a kind of a convention that if the right ventricle is bigger than the left ventricle, it's probably dilated. That's actually not the case on MRI, and the reason is because, again, generally on a 4-chamber view, you're trying to open up the right ventricle maximally, and we know that the true volume of the RV is actually bigger than the volume of the LV, so the RV should be bigger than the LV. So here's an example of some cases here where we're imaging the right ventricle, where you can see a significantly dilated RV here. And so this is just kind of the appropriateness criteria of where MRI is useful. RV is clearly one of the indications where MRI would be useful. Showing you some example cases of a patient with a normal right ventricle. A patient on the left-hand side here who has severe RV dysfunction. You can see this right ventricle is not moving much at all. And on the right-hand side, a patient with severe RV dilatation. And you'll notice in a patient with severe RV dilatation that the left ventricle can appear small. Okay, so let's go now. And then obviously also important to look at the wall thickness. This is a patient who has a very increased thickness of the right ventricular free wall. So this is severe right ventricular hypertrophy. Now, what are the specific views that we obtain? So, on the left ventricle, we have our standard short axis and our 2, 3, and 4-chamber views. Here, for the right ventricle, there are certain specific views that we would try to get as well. So obviously, the 4-chamber view is the first view that you have, which shows you the right ventricle, and the short axis view that we have also show you the right ventricle as well. But then you're going to also want to try to prescribe this 3-chamber view of the right ventricle, sometimes called the inflow-outflow view. And that's really generally done by prescribing it almost vertically in the right ventricle, trying to go between the bisecting the tricuspid valve and just go a little bit off to the side of the RV apex. And it shows you this view right here. And this view is really good for looking at the subtricuspid region, so the area that's below the tricuspid valve, and also for looking at the infundibular region, the area underneath the pulmonic valve. And again, from this view right here, this RV 3-chamber view, the other structures that you're going to see, obviously the pulmonary artery, the superior vena cava you'll frequently see as it's coming into the right atrium, and oftentimes you'll have a little bit of the ascending aorta as well. So again, it's important when you see this view to recognize what the normal landmarks are, so you know what structures you're looking at. And again, this is a view you probably generally don't see in the echo lab. So again, it's important to recognize. And these are views, you can obtain these views from CT or MRI. The other view that's important to get is what we call the right ventricular outflow tract view. And so this view is done really by taking that 3-chamber view and actually going through the right ventricular outflow tract. And as a result, it shows you a 90-degree orthogonal view to the 3-chamber view. And this is good for a second view to look at the pulmonary valve, the pulmonary artery trunk, and then the right ventricular outflow tract. And again, this view is not useful for looking at the left ventricle. You happen to see a little bit of the LV, but it's really designed to look at the right ventricular outflow tract. And then obviously the standard short axis stack that we have. So again, you're not just obtaining 1 or 2 short axis views and trying to extrapolate. For assessment of the right ventricle, you're going to obtain a full series of images from base of the heart all the way to the apex of the heart. These images then, you would just summate the volume in each individual slice, add or multiply that by the distance between each slice to come up with a volume for each slice. Add those together, and therefore you come up with a volume. So this patient right here, if we went through and did the RV tracings, the planimetry, for every single short axis slice, and generally you're going to have about 6 to 10 short axis slices, depending upon the size of the right ventricle. This person has a right ventricular end diastolic volume of about 159 milliliters. You can do the same thing in systole, and that will give you then the RV and systolic volume. Now, what's the variability here? So the variability for the right ventricle, again, because of the unique shape, is a little bit, and also the irregular borders, is a little bit higher than the variability for the left ventricle. And so in most studies, the interstudy variability is on the order of about 5 to 10%. So where this is useful is really if you have a patient, one, that you want to get an accurate assessment of artery volumes or ejection fraction, that's where MRI can be useful for an initial assessment, but also important for serial assessment, for following serial changes in a patient who has a concern for right ventricular abnormalities, as well as right-sided valvular heart disease, pulmonic or tricuspid regurgitation. Serial MRI studies can be useful to follow the right ventricle. Now, as I mentioned at the very beginning, you don't want to just look at kind of relative sizes. You want to look at absolute sizes to say what's the size of this right ventricle. And the best way is, as I talked about, because it's a three-dimensional structure, is to look at the right ventricular volume. What we want to know is what are normal values. So there are predefined population-based normal values for the right ventricle. And this is one particular study published in European Heart Journal almost 20 years ago, which defined normal volumes by end diastolic and systolic volumes, as well as ejection fraction for the right ventricle. And again, this is a population of normal healthy volunteers. And you'll notice there's differences between men and women, right? Men tend to have larger right ventricles than women, although the ejection fraction between men and women is similar. And then also important to recognize, if we look at this cohort of normals and actually look at deciles of age, you'll notice several relationships. And so here what you've got is the median and then the 95% confidence interval is shown here in the parenthesis. And so the upper confidence interval here is really the upper limits of normal. So if you look at, for a young patient in their 20s, the upper limits of normal for an indexed RV volume may be as high as 114 mLs. Whereas for a patient in their 70s, upper limits of normal would be 98. So the point is that a size of the ventricle that could be completely normal for a young person may be considered dilated for an elderly person, and vice versa. You don't want to call a ventricle dilated in a young person and say they have RV dilatation when in fact it's just a normal RV size. Also recognize same way across deciles and across sex, there's differences between RV volumes between men and women. With age? Yeah, so because I'll show you the next thing. Oh, I don't know if I have that. Which is that the RV ejection fraction, if you look here, the RV ejection fraction, the lower limits of normal for RV ejection fraction goes up. So what happens as you get older, probably as just like with the left ventricle, as the ventricle becomes less compliant, the ventricle is not able to dilate up as much, and it becomes more, the ejection fraction starts to drop a little bit. Yep. Okay. And I think the main point, though, here is if you look at it, a lower limits of normal RV ejection fraction for a 70-year-old may be as low as 57. So if you're 50% RV ejection fraction will be considered abnormal in an 80-year-old, but it may actually be still within normal range for a young, 20-year-old or an 18-year-old. And again, this is where it's important, is you don't want to start labeling people as having disease when in fact this may be just a young person, it's just a young heart. Okay, so let's move now to how you would kind of do an assessment of RV volumes and ejection fraction. So what I showed you earlier was by doing off of the short axis stack. Now that short axis set of views, we normally obtain that to look at the left ventricle. So every case you do, you pretty much are going to do these. There's another way you could do it, which is you could actually do a stack of long axis views or axial stack of slices specifically to look at the right ventricle. And in this case, the advantages are this will allow you to see longitudinal motion a little bit better than the short axis views are. But the reality is, and this was a particular study done a few years ago, where somebody went through and did it both ways. So they had a bunch of patients, they scanned them both by short axis as well as the axial or long axis views, stack of views, and then said, okay, what's my stroke volume based on these two different methodologies, and how does that compare to the flow coming out of the pulmonary artery? Because that's, there should be, as long as there's no tricuspid regurgitation, the flow that the right ventricle ejects out, the stroke volume, should equal the flow coming out the pulmonary artery. So that was used as kind of the reference standard. And what they noticed really was that whether you did it by a axial long axis stack or by the short axis stack that we normally do anyway, the relationship was not that far different. And so really from a practical standpoint, we'll rarely do the long axis stack of the right ventricle because again, that requires a whole bunch of extra breath holds and a bunch of extra views. Now there's one caveat to that. There's one exception where you will specifically want to do that. And that's in patients who have Epstein's anomaly, where you have a very elongated tricuspid valve. And in those cases, the short axis views may be very misleading because you need to really identify what's the atrialized part of the ventricle, or what's atrium and what's ventricle, and those leaflets can make it very difficult. So there's a specific scenario where you will do a long axis stack, but most of those are going to be the congenital patients. Let's start off now. So I want to break it up here before I turn it over to Dr. Ahmed. Let's look at a couple cases. Okay, so I'm going to show you one case here, and I've got it right here. And I want you can see it. And should I zoom it up more? I want somebody in the audience here to tell me, do we have microphones? No mics. Okay. So you have to speak louder. I'll repeat what you say. So here's a stack of short axis views, and then here's long axis views. Tell me what you see. Somebody. Okay, so who said that? Yes. Okay, so RV is dilated, right? You look at this, you look at this, you look at this. And again, you're not just going to compare to the LV size. We'll look at the absolute values. But yes, this RV is big. Okay, what else? Yes. So and show me which view you're talking about. Which series number do you want me to click on? Which? 29, right here. Okay. Yeah. So what do you think about that? So it's not so much, certainly there's some trabeculations here, but actually the wall itself, right? How does it look? Looks, okay, that's good. So because very important, the first step is just to recognize it's different. And I'll tell you, one of the things I'll frequently do, if I see something that looks unusual, I'll say, let me go pull up 10 normal cases, right? And say, how does this structure, this area look on normals? Is this abnormal? Is this different? Yes, so you're absolutely right. It looks different. Now, tell me more than that, or somebody else. You can pass it on. Okay, so the septum, you're wondering if it's a little bit flattened, and I agree with you. And this view is not the best for that. The short axis views will be better, right? And I agree with you. It does look like there's some flattening of the septum, okay? Does it look like it's in systole or diastole or both or what? Yeah, so it's probably a little bit of both, right? Again, this is not the most overt case of septal flattening, but there is some flattening, which again goes along with it. There's some RV overload, right? As Dr. Naga talked to you about last week, if you have volume overload, when does that cause the systolic flattening? In systole or diastole? Diastole. If you have pressure overload, when does it cause it? Systole, but it could also then affect diastole as well, right? Okay. And in this case, you say, okay, I see some mild, and it may be in both, so it may make you think there may be some pressure overload to this right ventricle. The right ventricle is big. And then going back again to the wall, the free wall? Okay, so she's going right to the answer. So let's you're absolutely right, but let me walk you through this, right? So one is there's a very irregular shape, right? Some people oftentimes refer to it as kind of like an accordion sign almost, right? It's like an accordion, right? You see this? The other thing is also, what about motion? Does motion here look normal or abnormal? Right? It's not normal motion. There's irregular motion, right? And then, so already you say, okay, I've got some abnormality of the right ventricular contractility. I've got abnormality of the right ventricular thickness, where it's almost like an accordion, where there's increases and decreases in thickness. And then, importantly, don't just look at one or two views. Let's scour through all the views we have, and then we'll come back to this in a second. I'm going to scroll down to the bottom here because I've got some of the magic shots. And first off, which view is this of the right ventricle? Remember I told you guys about this? Which one? Right, the RV inflow-outflow view or three-chamber view. Yep. And what do we see here? So this is a superior vena cava here. When you come down, what? Sorry. So there's a tricuspid valve. There's a right ventricle. Above the tricuspid valve here? Here? This right here? This looks dilated? No, I mean, so on this view, you don't want to look at because again, just depending upon where you did the cut, you can make it, because it actually looks small, if anything, but depending upon where you did the cut can affect it, right? Because if you're not going through the center of it. So I'm going to draw your attention more to not the inflow, but look at the outflow. Yes. So our CT fellow is going to say, look, right here. See, you're used to seeing this, the RV very nicely on the CT as well, as Dr. Ahmed will show. What do you see here? There's a little outpouching here, right? So there's actually an aneurysm here as well. So this person has wall motion abnormalities and aneurysm. So you were worried about the diagnosis of RV dysplasia, right? So now recognize the way you make that diagnosis, you have specific criteria, right? It's not just kind of, I see it, right? So we have specific criteria. What are those specific criteria for RV dysplasia? Okay, so I'm going to tell you for this patient, again, we went through and did so there's dysfunction of the right ventricle, there's irregular shape, there's an aneurysm. These are the RV volumes here. So 200 cc RV ejection fraction is 38%. So now these are the specific imaging criteria for RV dysplasia. So you have major and minor criteria. First thing though, remember, you got to have a wall motion abnormality. You got to have either RV akinesis, dyskinesis, desynchronous contraction, thinning, or aneurysm, right? In other words, so don't tell me it's RV dysplasia just because the EF is low, right? Because that could just be, again, from left-sided heart disease. You got to have an abnormality of the right ventricular, a regional abnormality of right ventricular motion first. Once you have that, then we look at these quantitative criteria, and it's really based on size and function. And so major criteria would be if the RV ejection fraction is less than 40%. So again, first you got to have a wall motion abnormality, and then RV ejection fraction less than 40%. That's a major criteria for RV dysplasia. Or based on dilatation, and for dilatation, it's if the RV end diastolic volume index. So again, you got to index this to BSA, and it's also sex specific. Because remember I showed you earlier, men and women have different size right ventricles normally. So the threshold value is 110 milliliters per meter square for men, or 100 milliliters per meter square for women. So again, for the general cardiology fellows, you don't have to memorize these numbers. The MRI fellows, you do have to memorize these numbers because they may get asked on the MRI boards. So that's major criteria. You also then have minor criteria, which again, you have to have a wall motion abnormality. But then on top of that, you have to have RV dilatation that's not as pronounced. So it's basically for men, if it's over 100, that's a minor criteria. For women, if it's over 90, that represents a minor criteria, or if the ejection fraction is between 40 and 45. So again, less dysfunction, less dilatation than a major criteria. Yes? Yeah, so in these criteria, there isn't a specific adjustment that's made for age. It was just made for sex. That's where, I mean, use your judgment. But, when I showed you kind of what normal RV ejection fraction and RV size values were, where you sometimes will run into this problem is if you have especially a young male who's athletic, his RV can be big, but it may not have anything to do with any pathological process. But again, that's where you go back to that first criteria is you got to have a regional abnormality. Most of those cases that are athletic or that the heart is big, they don't have a regional abnormality. They just have a sluggish ventricle, but it could just be an athlete, right? So there isn't a specific age differentiation, but there is a sex differentiation. Okay, so this is an example of a patient who meets the criteria, major criteria for RV dysplasia. Also important to recognize where the areas that RV dysplasia tends to affect. And so the areas that affects, obviously the free wall, but really the areas that it tends to have an effect on is the subtricuspid region and the right ventricular outflow tract region. And in this patient, remember the aneurysm was in the right ventricular outflow tract. So that's why, again, we do those extra views, not just the standard short axis views, to look at these other areas of the ventricle. And then also recognize we're also learning that it's not sometimes confined to the right ventricle. There can also be associated LV pathology, and it can oftentimes affect the posterolateral wall of the left ventricle as well. Okay, so let's go to another case now. And I want you guys, somebody to tell me what they see here. So let me zoom in here. And again, when you look at these, I mean, obviously this is an RV talk, so you're going to try to gravitate to the RV, but go systematically. Look at the LV first, right? Look at LV size, LV function, LV morphology, and then go to the right ventricle. Look at RV size, RV function, RV morphology. What do you guys see? Right. Okay, so RV is very big. Okay. Okay. And where do you see that? Because by definition, can the RV be dyskinetic everywhere? Right. In 17, let's see. Yes. Okay. So you're seeing this area right here? Okay. And and let me go back and look at the short axis views, because anytime you see an abnormality, you want to make sure you see it also in the orthogonal view. So if I have a four-chamber view, what part of the right ventricle would that be looking at? Yeah, so it'd be kind of this area right here, right? Because remember, the four-chamber view is done like this, right? So it's this area. So do you see abnormality here as well? You do, right? So you want confirmation, because like a true abnormality will occur no matter what angle you look at it from. Whereas if it's an artifact, or if it's an obscure plane, you won't see that. So here you do see it, right? And actually you can see it very nicely here. You've got a big abnormality here, right? So RV is big, and you've got dysfunction here in this area. What about the LV? Yeah, this one I'd be careful about, because it may just be, again, you're foreshortening a little bit. Because if you look at the short axis view down at the apex, how does it look? Okay. Yeah, it doesn't look, and then if you look at it from a regional standpoint, does it look like, if you look at the top half of the heart, look at the bottom half of the heart, does it look like there's a little bit of a difference? Yeah, so this area right here, right? It's subtle, but if you look at it, I would probably agree with you that the kind of the infraseptum inferior wall maybe is not as good as the anterior wall, right? So again, this is where recognized on MRI, I think besides assessing motion, assessing morphology and chamber sizes, you also have this other technique, which is really kind of the gold standard technique for looking for scar tissue and infarction. This is your late gallium enhancement, and what do you see here? And so remember, for those of you, what you're looking for is bright areas. Bright areas represent scar or infarct, right? And black represents normal. What? Yes, where do you see it? I'm going to click on one view to. Right, so it's inferior. See this inferior wall right here, and look at this RV as well. No, so this is, well, the RV insertion point is here, but this is more than that, because this is a full thickness infarct of the LV. What does that make? Infarct. Right, so this person has an RCA infarction, inferior wall infarct, with associated RV infarction as well, right? And so, and that's what you'll generally see is if the RV is affected also, it's going to be in this kind of diaphragmatic portion, sometimes all the way out to the free wall, depending upon how high up, how many acute marginal branches get knocked off. Okay, so this person has a inferior wall infarction with associated RV infarction. Now, how many of you have seen an RV infarct before? Like, not seen RV motion, actually seen the infarct. I'm showing you the infarct. Have you seen that before? I'm showing you the bright areas here is the infarct, right? So you may infer that based on looking at motion, but here you can actually see the actual infarct itself. Okay, so where is this important is obviously we know when you guys are taking care of patients in the hospital or in the CCU, patients who have RV infarct, they're going to have a much more complicated course, right? Because again, the LV infarct, the size of the inferior wall infarct is not huge, right? But it's affecting the RV as well. And as a result, your RV is quite dilated and the RV ejection fraction is quite reduced. These are just some of the clinical findings you'll see. In the interest of time, I'm going to skip past this. And we know that for patients who present with an infarct, if they have RV infarction as well, their prognosis is worse. So let me wrap up here, then I'll turn it over to Dr. Ahmed to talk about CT. So CMR, I think, provides excellent visualization for the right ventricle and really allows optimal assessment of RV size, function, and RV wall abnormalities. Low variability, therefore it's useful for serial measurements. And really, this is the only technique that allows you to directly identify, visualize infarction in the right ventricle. Thank you for your attention.
All right. Good afternoon, everyone. So we'll switch modalities, and I'll talk to you briefly about how we can utilize CT for evaluation of RV function. And of course, you must be wondering why are we even talking about it. We have MRI, which is excellent for CT. And of course, CT is not first line for evaluation of RV function, but I will show you the data that we have from quite a few papers that does show how CT can be helpful for evaluation of RV in specific indications, and then also how it correlates with MRI, which is the gold standard for assessment of RV function and volumes. So this is a nice review from Jack, I think in 2023, which goes over the different modalities and how they can be useful for assessment of right heart function from Dr. Rebecca Hahn. And so this is a nice review figure from that paper. Dr. Shah already went over the different pathologies that are for which RV function evaluation is very important, both that cause RV pressure and volume overload. Some of these are right and left-sided heart failure, pulmonary hypertension, different cardiomyopathies, of course, congenital heart disease and valvular heart disease. And you all know what are the echo parameters we look for assessment of RV function. You heard about that last week. For CT, similar to MRI, we're looking at RV volumes and ejection fractions. And also, remember, CT has very good anatomical delineation of the neighboring structures. So you can, especially in valvular and congenital heart disease cases, you can look at the connections of the different chambers and the valves very nicely as well. The paper goes over the strengths and limitations of the different modalities for evaluation of RV function. For CT, of course, the strength is that it's a 3D acquisition. So unlike echo, it's independent of geometric assumptions and free from acoustic window limitations. But it does involve radiation. And if you're going to evaluate RV for CT, you have to do retrospective gating. So it's even more radiation. You have to use contrast, and I'll go over the protocol that we use if we want to look at RV as well when we're performing CT. It requires a stable cardiac rhythm. It does have a lower temporal resolution, especially compared to echo, and the patients have to be clinically stable to undergo this. Its use is mostly in patients who are undergoing CT for other clinical indications. It's rare that you're going to order a CT just for assessment of RV function. For example, congenital heart disease patients that are referred for CT, we look at the RV function as well. Patients with a valve percutaneous intervention, especially being considered for TTVR, that's a retrospective scan anyway, so we always give RV function as well. Also on the TAVR reports that you guys see, we give LV and RV function as well because it's a retrospective acquisition. So cardiac MRI, as I mentioned, is the gold standard, but CT is a valuable alternative in patients with insufficient echo information when the cardiac MRI is not available or you cannot perform it, for example, in patients with LVAD. So there is data out there, a few papers that look at the association of CT RV parameters with outcomes. There is data in aortic stenosis patients, and this has been studied because we have data on so many TAVR patients. where we can look at LV and RV function. And in these patients, RV dysfunction can contribute to their morbidity and mortality. And from one paper, RV volume index as assessed by CT of greater than 120 mLs per meter square was independently associated with an increased risk of 1-year mortality in TAVR patients. Similarly, RV ejection fraction assessed by CT less than 50% was an indicator. And there is a way, if you have the appropriate software, to perform long axis strain for the RV free wall, and values below a certain threshold are also suggestive of worse outcomes. This is a paper from International Journal of Cardiology that looked at the association of CT-RV parameters with outcomes in patients with tricuspid valve disease that were undergoing tricuspid valve surgery for tricuspid regurgitation. And they measured the tricuspid annulus diameter in a 4-chamber view, so similar to the MRI 4-chamber view. And then you can also construct an RA-RV sort of 2-chamber view for the right side. And this is how they measured from the tricuspid annulus, just giving an example. They also looked at something from an on-FOS view of the tricuspid annulus, something called the sphericity index. From this paper, they have a couple of findings that a tricuspid valve annulus diameter greater than 29, index 29 millimeters per meter square from a 4-chamber view, as measured like this, is an independent predictor for post-op RV dysfunction after tricuspid valve surgery, and then also an RV end diastolic volume index greater than 129 is a predictor of RV dysfunction after tricuspid valve surgery. This is a nice review paper from one of my prior colleagues, Dr. Trong, that goes over the analysis of ventricular function by CT. This is in JCCT 2015, if you want to look it up. A lot of the review obviously has been taken up by LV, but they do talk about assessment of RV function by CT as well. And they emphasize that for RV evaluation, adequate contrast enhancement of the RV lumen is required. So what is the CT protocol if RV evaluation is desired? Our CT fellows know this. This we take for granted, but you need at least a 64-slice CT if you're going to perform RV or LV function on a CT. The minimal contrast rate has to be 5 mLs per second. You obviously need retrospective EKG gating so that you have all phases of the cardiac cycle. There are tube current modulation techniques where it will drop the milliamperes during systole. So the images are still good enough that you can delineate the endocardial borders in the systolic phases, but it's saving the patient some radiation by dropping it down in systolic phases. The contrast is typically time for the arterial phase because a lot of these scans are being done for TAVR or for coronary arteries. As you know, that scan acquisition means that scan's going to start 4 to 5 seconds after peak aortic opacification. But for the RV to be visible, especially the endocardial borders to be clearly visible, you have to run the contrast longer. So we run it typically for an additional 10 seconds. Sometimes we'll do a chaser, which is a mixture half and half of the saline and contrast. So if you know ahead of time, a lot of congenital cases that we are going to look at the RV as well, you have to go over the protocol with the tech so they run contrast for a longer period of time. So we remember CT is on MRI, we're prescribing the slices and the short axis one by one. CT is already a 3D acquisition. So you could start doing RV function by every 0.5 millimeters, that's the lowest thickness with the force, with the photon counting, it's even lower now. But there's no point of doing that. Typically 1.5 millimeter slices are good enough. Reconstruction is at 10% increments, which is 10 phases for single source CTs. But here we have Siemens scanner, and as you know, Siemens pioneered the dual source technology. So if you have dual source CT to make full use of that technology, you can have 20 phases per cardiac cycle at every 5%. And the reason for that is the temporal resolution is much better with dual source CTs. For single source CTs, it's around 160 to 170 milliseconds, and it's much better, 60 to 70 milliseconds for dual source CT. So it doesn't make sense to do every 5% if you're going to have a single source CT scanner. And the reason for that is if you think about it, for example, at a heart rate of 60 beats per minute. The difference between each phase is 100 milliseconds at 10 phases. So if your temporal resolution is 160 milliseconds, there's no point doing that. But with the dual source scanner, your temporal resolution is below 100 for sure, so you can do every 5% increments to take full advantage of the temporal resolution. The process is similar to MRI. You draw the endocardial borders in end-systole and in diastole. There are automatic softwares there, but unlike LV, RV, just like MRI, if you're using automated contour detection, may need quite a bit of editing. So the potential utility of cardiac CT, as I mentioned, patients with inadequate echo information and contraindications to cardiac MRI, patients with a lot of hardware, pacemakers, defibrillators, complex and congenital heart disease patients, utilizing timing of pulmonic valve replacement, for example, in patients with tetralogy of low follow-up. A lot of the data went to replace based on RV and diastolic volume indexes based on MRI studies, but we borrow that data from MRI. Also, there is no normative data for CT for volumes and ejection fractions because there are no large studies that have looked at that. So we again borrowed that data from cardiac MRI. Assessment of RV function in patients with LVADs, because you're not going to do MRI on these patients, and I'll go through that. It can be useful in assessment of ARVDs. Dr. Shah showed you a clinical case, and I'll show you a paper that addresses that. And then this obviously gives you additional information regarding RV size and function in patients who are already undergoing CT for another indication, such as a TAVR or a TTVR. So the software will construct these curves for you. Here, this line is the end systolic, this is end diastolic, so obviously gives you the stroke volume and your ejection fractions. These are the contours at end systole and diastole. And you can see the images are pretty crisp. The endocardial definition just as good as cardiac MRI. This is our scanner here, so you can see this 5% increments here because we use the dual source scanners. These are the basal, mid, and apical slices. So like I mentioned, no need to reconstruct at slice thickness less than 1.5. 1.5 millimeter is good enough. And then this is evaluation. So how does it compare to the gold standard, which is cardiac MRI? This paper from International Journal of Cardiology from China looked at 47 patients who both had a 64-slice CT done and cardiac MRI. And using MRI as the reference standard, they compared CT with that. And they also looked at the intra-observer and inter-observer variability. So if you look at these four parameters and diastolic volume, systolic volume, stroke volume, and ejection fraction, the correlation coefficients are excellent between MRI and CT, at least based from this study. And these are the Blown-Altman plots. Just to recap, the solid line here is the mean difference between the two modalities, and these are the dotted lines are the 95% confidence interval. So if most of your dots are following between the 95% confidence intervals, that means there is a good correlation. They also looked at inter and intra-observer variability for both MRI and CT and compared it. According to this paper, at least, they concluded that inter-observer variability of CT was better than MRI, but intra-observer was lower with CT. And this is a nice meta-analysis looking at the same thing, which is the comparison of cardiac CT with cardiac MRI for RV assessment. This is meta-analysis from I believe a group in Korea, in Korean Journal of Radiology. They looked at 766 patients from 20 studies. And again, they showed that the correlation coefficient for these four parameters and diastolic volume, systolic volume, stroke volume, and ejection fraction is excellent between the two modalities. So let's move on to one of the indications for RV evaluation by CT, which is in LVAD patients. This is a paper in Journal of Heart and Lung Transplantation, which looked at assessment of RV function in LVAD patients. So as you know, RV failure is a major contributor to morbidity and mortality after LVAD implantation, and evaluation by echo is challenging with all the hardware there. So here is the anatomy of a HeartMate 2 device. You can see it very well, the inflow cannula coming out of the RV apex, the outflow cannula. This is the image pre-contrast in the planning scan, and this is post-contrast. So I'm going to skip this slide. So this is the challenge with echo. When they ask the readers to rate the study quality of baseline echo versus echo after LVAD implant, you can see 60% had good images at baseline, but only 15% have good images post LVAD, and that's just because of all the artifact. When they try to look at the correlation of different echo parameters with CT in these patients with LVAD, they found that RV fractional area change on echo had the best correlation with CT-derived RV ejection fraction, and TAPC and S to L ratio, with the short axis to long axis ratio, something else that looked at, had poor correlation. In addition, CT can give you other useful information in LVAD patients because it can pick up other pathologies. So in half of their patients, they picked up other pathologies or findings, such as cannula malposition, intracannula thrombus in the left atrial appendage, pericardial effusion, and hematoma. Here is an example of low attenuation thrombus in the outflow cannula. This is malpositioning of the inflow cannula. It's butting against the septal wall. There's an anterior mediastinal hematoma, and then here is a left atrial appendage clot. So, of course, CT will give you more than just the function. This is a case from here at Methodist of a 73-year-old patient who had an LVAD implanted a couple of months ago for non-ischemic cardiomyopathy. So the standard parasternal long axis view is showing the RV free wall fairly well, and the RV function doesn't seem to be too bad, but here the tech is attempting to do sort of a modified 5-chamber view. Here's the RV free wall. I don't think you can see my mouse, but it is challenging. So this echo was read as having normal RV size and mildly depressed RV function. This is a CT acquisition on the same patient. So you can see I've put 3 slices here from CT, basal, mid, and apical. So at the apex, because now you're getting close to the inflow cannula, you can start to see some artifact, but still, I think the endocardial borders are fairly good, both at end-systole and end-diastole, for evaluation of RV function. So by CT analysis, this patient had an RV ejection fraction of 40%, and the RV was mildly enlarged by RV volumes. CT can be helpful in evaluation of ARVD. This group from Japan published this paper in JCCT in 2013, where they tried to come up with a CT scoring system for diagnosis of ARVD. The study was looking at 77 patients retrospectively over the preceding 4 years who had a CT done with and without contrast and were suspecting of having ARVD. And they kind of came up with a few different CT findings, which I'll show you on the next slide, that they graded. And then they tried to compare the utility of the scoring system on CT that they were proposing against the 2010 task force criteria as the reference standard. This is that task force criteria. It's long. Imaging is only one part of it, remember. Dr. Shah showed you the imaging criteria, which goes over the RV ejection fraction, and then less than 40%, and also the RV wall motion abnormalities, which is key. And there are major and minor criteria, and you get either a definitive, borderline, or possible diagnosis based on the number of major and minor points you have. And then, of course, other than imaging, there is the tissue characterization and all the EP abnormalities and family history that go into it. So this was their scoring system. They looked at fatty infiltration of the RV free wall and gave it major or 2 points if it was at multiple places or if the entire RV free wall was thinned out, and then minor if it was only at 1 point. And then bulging or aneurysm of the RV free wall is very important. So depending on the how deep it was, the bulge, they gave it 2 or 1 points, less than 5 millimeter or more than 5 millimeter, and then dilatation of the right ventricle. These are examples from their paper. This is a non-contrast CT showing fat in the RV free wall. This is post-contrast showing trabeculations, and again showing fat here. This is an area of bulge of the RV free wall, contrast enhanced scan, dilated RV as you can see, and this is the histopathology. So when compared against the task force criteria, their scoring system had decent diagnostic ability for prediction of ARVD with the specificity of 94% and a positive predictive value of 87%. Of course, a lot of the things that we talked about, RV dilatation, RV wall motion abnormalities, aneurysms, areas of dyskinesia, fatty infiltration, those are all the things that CT can look at. This is an interesting case because this was one of the days when I was reading CTs. This was just a referral for a coronary CT in a 65-year-old female. So we, of course, read the coronaries, and she had some plaque, but what she also had this ARVD, which was not known. And you can, Dr. Shah was calling this accordion sign. You can see the lumpy, bumpy appearance of the RV free wall. And then they were also, on the non-contrast scan, more apparent. There were areas of fatty invaginations into the RV free wall. Here. So you can see one area here and then one here. And then lastly, just a very basic thing that CT can provide us in patients with pulmonary embolism. So radiologists will usually look at something called the RV-LV ratio. It's straightforward. It's based on an axial slice where you see the biggest RV dimension, and you measure it from the inner wall to inner wall for RV and LV. And the normal ratio is 0.6 to 1, and a ratio of greater than 1 in patients with acute pulmonary embolism is predictive of adverse outcome. And this is one paper that looked at this ratio, but also looked at the ratio of RV and LV volumes. And this correlated with the detection of right ventricular dysfunction in PE patients. That's all I have. Thank you very much.